Let's say that you have got a 25-year-old man. He comes to you with sudden painless loss of vision. And when you check the blood pressure seems to be dangerously high. And he gives you a family history of maybe my father had a stroke at a very young age, that kind of a history. You do the imaging and you see that there are tumors in the brain and there are tumors also in the eyes, specifically saying in the retina. Now, a single gene is going to explain the entire scenario of what's going on over here. This is Azim Mimdani from Pursuit of Medicine. Today, let's understand von Hippel-Lindau disease from the very basic. Now, let's start with what is von Hippel-Lindau disease. Now, von Hippel-Lindau disease is an autosomal dominant inherited cancer predisposition syndrome. What do we mean by this? Let's break it down a little bit. When I say autosomal, I mean to say that it is not on the sex chromosomes, it is on the autosome. It is on the autosome region, mean one of the 44 autosomes that we have got. And when I say dominant, it means that one defective copy is enough to cause disease. You don't need two defective copies of the gene. A single gene can cause the disease. Okay, but this single gene has to be defective. Now, it's a cancer predisposition syndrome. When I say cancer predisposition, it means that this condition produces or predisposes the individual towards certain cancer. But the good thing is these are not some random cancer. These cancers are highly specific and they occur at a young age. Most important is that you can predict what type of cancer the person is going to get. This is most important, that you can predict what type of cancer the person can get. Now, whenever we say syndrome, whenever we use the word syndrome in medicine, what we mean to say is that multiple organ systems are involved. Okay, so a single gene defect over here affects multiple organ systems of the body. Now let's go at the very basic level. Why does this VHL disease happens? Now at the chromosome 3p, at this chromosome 3p, there is a gene called as VHL gene. You and me, all normal people have got VHL gene in our bodies, two sets of these genes in our bodies, and the problem starts when these VHL gene becomes defective. Even if one pair of the gene becomes defective, then the problem starts. Now, to understand VHL disease, we need to understand this key protein which is called as HIF1 alpha. Now, whenever the oxygen is less, HIF1 alpha is going to be on. And whenever the oxygen is normal, then what's going to happen is HIF1 alpha is going to be off. When if oxygen is less and if HIF1 alpha is on, if oxygen is less, it means that HIF1 alpha is on, switched on. And whenever it switches on, it prepares the body for low oxygen. It tells the body that, hey, we are hypoxic, let's prepare for less oxygen. And how does body basically prepare for less oxygen? It prepares by making something called as VEGF and erythropoietin, and basically we have got n number of chemicals. What do these do? Like for example, VEGF, it serves as a signal to make more blood vessel, division of blood vessels. Okay, whenever VEGF is secreted, more blood vessels are allocated to that area. And erythropoietin makes more RBC. I hope you know that. So basically, the job of HIF1 alpha is to prepare the body for hypoxia. It's to say the body that we have got to work under less oxygen. So let's make more blood vessel, let's make more RBC, let's produce more of those supportive tissue that prepares the body for hypoxia. What I like to think is of HIF1 alpha. This your HIF1 alpha over here. This is like a loyal servant who is over dedicated, he is a hyper workaholic, and he keeps doing his job. So he keeps doing angiogenesis, he keeps producing erythropoietin and all of these chemicals, preparing the body for hypoxia. But we need somebody behind this HIF1 alpha to go and tell the HIF1 alpha to relax a bit. We do not have got oxygen shortage. It's okay if you don't work for a while. And so we need somebody behind that HIF1 alpha to stop the HIF1 alpha. And this is where comes your normal VHL protein. Okay. So the normal VHL protein, von Hippel-Lindau disease protein produced by von Hippel-Lindau disease gene, senses the normal oxygen. Whenever it senses the normal oxygen, it goes and it destroys the HIF1 alpha. Now, when HIF1 alpha is destroyed, these signals for more angiogenesis, production of more blood vessels, production of more tissue, production of more RBC is going to get decreased. Now, what happens in VHL disease is that since we do not have a functioning VHL gene or a functioning VHL protein from the gene, we do not have a functioning VHL protein from the gene, the HIF1 alpha, it goes out all gun blazing like this. Like I'm showing you in this image, like this, it goes out all gun blazing, and it increases the angiogenesis. It goes out producing VEGF. VEGF increases the angiogenesis. It goes out with PDGF, and TGF alpha. It causes continuous cell proliferation. What is the net result? So the net result is that we have got highly vascular tumors with uncontrolled growth. This is basically the core idea of VHL, that we have got a loss of tumor suppressor gene which causes unchecked angiogenesis leading to highly vascular tumors. Now let's discuss the type of tumors we get in VHL disease. The hallmark tumor is a hemangioblastoma. What do we mean by hemangioblastoma? Let's do a word breakdown of this. I like to do word breakdown. Heme plus angio means blood vessels, and blast, the word blast, wherever you see the word blast in medicine, it basically means immature cells. It means immature cells. And when we got oma, it just means tumor. So we have got a tumor of immature blood cells. We have got hemangioblastomas, and where have we got hemangioblastomas? We have got hemangioblastomas in the CNS and in the eye. That's what is important. Coming to where exactly are these tumors in the CNS? In the CNS, there can be in the cerebellum, they can be in the cerebellum, they can be in the brainstem, in the spinal cord. When I come to the eye, in the eye, it's characteristically in the retina. So remember, it's in the cerebellum, it's in the brainstem, and it's in the retina. It's just not cerebral cortex basically. Anything below the cerebral cortex, cerebellum, brainstem, and the eyes retina, these have you have got hemangioblastomas over there. Very easy to remember. Other high yield thing is that these patients of VHL disease, they have got pheochromocytomas. Now, what are pheochromocytomas? Pheochromocytomas are catecholamine producing tumor. So basically, they produce your catecholamine, adrenaline, and noradrenaline. So you have got your catecholamines, and what do they cause? They cause high blood pressure, hypertension, okay, high BP. We have got your high BP, and catecholamines also cause headaches. They also cause sweating. They also cause palpitations. So what have we got? We have got a catecholamine producing a tumor, and because of catecholamine production, there's going to be high blood pressure, there's going to be headaches, there's going to be sweating, there's going to be palpitations. And the most important thing you need to know over here is that the hypertension produced by the catecholamines is a secondary hypertension. It is not a primary or essential hypertension. 95% or 90% of cases of hypertension are essential. But VHL disease is a cause, or particularly speaking, pheochromocytomas are a cause of secondary hypertension. Now, this has to explain the history of early brain stroke and early brain hemorrhages happening in patients with VHL disease. Coming to the kidneys, in the kidneys we see something called as clear cell renal cell carcinoma. What is this variety? Okay, so there are four varieties of RCCs. When we speak of the clear cell renal cell carcinoma, what do we mean to say is that basically what happens is that if this is a renal cell, let's say that this is a renal cell. In this particular type of carcinoma, what happens is that the renal cell gets swollen up. This is the nucleolus, I think. This gets swollen up by lipids and by glycogen. Now, when we take a biopsy and we do the histopathology, we see it under the microscope. These cells become sort of squashed. So all of the lipid and the glycogen escapes, and what you see in the biopsy is basically a squashed cell which is having a clear cytoplasm and just the nucleus. The cytoplasm is very clear. That is why it is called as a clear cell variant. Okay, clear cell carcinoma doesn't mean that the cancer cell in the patient is not having anything. It means that when you see in the microscope, you do not see anything in the cytoplasm because all of the cytoplasm and lipid have been squashed up. One thing I want you to know, very important, most common cause of death in VHL disease is due to the kidney tumors. VHL can also cause tumors in the ear, particularly in the endolymphatic sac, and it can cause hearing loss, tinnitus, and vertigo. Many times you see that these patients also give a family history of hearing loss. Coming to the pancreas, in VHL disease, what you get is pancreatic cyst, not tumors. Okay, remember that these are pancreatic cysts. And by not tumors, I mean specifically not functional. What do I mean by not functional? Not functional, I mean that they do not produce any hormones. Very, 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 very important. The tumors over here are just cysts. They do not produce hormones. Okay, you should know this. And so many times these are just incidental findings when it comes to pancreatic cysts. Now, this is very important. Why are patients of VHL disease prone to hemorrhage? It's because that on one side we have got the unchecked angiogenesis that is happening. So on one side we have got unchecked angiogenesis. There's going to be more number of blood vessels. On the other side, what do you have is basically high blood pressure. Now, this unchecked angiogenesis and the high blood pressure, unchecked angiogenesis, by the way, is by VEGF. VEGF is produced by HIF1 alpha. HIF1 alpha produces VEGF. VEGF causes unchecked angiogenesis and the high blood pressure. High blood pressure is due to the epinephrine and non-epinephrine produced by the adrenal tumor. ठीक है, तो both of these they go and they prepare this cocktail. This cocktail is very, very dangerous. This is the perfect setup for hemorrhage. Very deadly. On one side you have got high blood pressure. On other side you have got many blood vessels happening. So the patient is very susceptible to develop what you call brain hemorrhages. That is why other than renal cell carcinoma, the other cause of death in this kind of patients is generally the intracranial bleeding. Coming to the management, the core principle behind the management of VHL is that we do not cure it, we anticipate it. This is very important. There is no cure for the disease. All we can do is we can do lifelong surveillance. And what do we need to do? We need to go ahead of the tumors. Basically, before a tumor develops, before it starts to create too much of problem, we need to go and we need to get rid of that tumor, and we need to keep surveillance, continuous surveillance. So this is very important. Exam point of view, high yield, especially USMLE, MRCP, And even the Indian PG exams, very important. You need to remember this. What are the screening tests to be done? Okay, the screening test to be done is annual eye exam and MRI of the brain and spine. They can confuse you whether you need to do MRI or CT. These are very important. Never, ever, ever forget this slide. These four tests will be asked in one way or the other way if they want to give a question on VHL disease. This is where they like to confuse whether he needs the patient needs annual eye exam, whether he needs a colonoscopy every year. This is where they generally confuse in exams like your USMLE, MRCP. Now, since there is no cure for VHL disease, what we do is we do a lesion specific treatment. For example, let's talk about the treatment of hemangioblastomas. Hemangioblastomas, how do you treat them? You treat them if the tumor gets too big. Suppose there is a tumor occurring in the brain. Okay, in the brain, this is the brain and this is the tumor. You see the tumor with an MRI. It's not causing any symptoms. It's not producing damage to the nearby structure, not compressing any nerve, not increasing the intracranial pressure. Fine, let it be there. Just let it be there. Keep surveillance. The tumor becomes too big over the period of time, or the tumor is compressing the nearby structures, causing any neurological problem. Then you go in and then you resect the tumor. Till then, you don't do unnecessary surgery, because if you do unnecessary surgery, even if you remove the tumor when the tumor is very small, after 1 year, after 2 years, there is going to be another tumor. Again, you have to remove the tumor. This disease causes regular repeated tumor growth. So how many tumors will you remove? You remove only the tumor which needs to be removed. Secondly, let's say if there is retinal lesions, okay, there is problem in the retina. There are retinal lesions. What you can do? You can go in and you can do your laser therapy. Let's say that there is a pheochromocytoma. Okay, I'm typing pheochromocytoma over here. Whenever there is a pheochromocytoma, it's causing these high blood pressure. You wanna surgically remove the pheochromocytoma, but remember this, that before surgery always you need to go that always go for alpha blockade first, very important, and then beta blockers. Why? Because if you give beta blockers earlier, that's gonna cause unchecked alpha receptor stimulation. So never give beta blockers first. This is again very high yield for examinations, that you give alpha blockers first, then you give beta blockers. Lastly, if there is any renal cell carcinoma, RCC, what you do is a nephron sparing surgery. What is the take home message? All you can do is scan early, treat selectively, and preserve organs. Alright, so that was one Hippel Lindau disease explained from the very basic. If you liked my channel, please subscribe. I make more of such conceptual videos. Alright, take care. Bye bye.